Great. Well, switching gears entirely, and I think the ARS questions that you saw were related to this case, but if I could have Maria Brew, who's professor of medicine at the University of Miami, Anita Afzali from the Ohio State University, Kim Isaacs, who's from UNC, and Susie Kane from Mayo Clinic. And these will be challenges in the care of the pregnant IBD patient. Just to give you a preview before we get to the cases and the discussion, the first case is going to be a 27-year-old female with severe ulcerative colitis in deep remission for 2 years on anti-TNF and azathioprine, who tells you, I want to get pregnant, can I stop all of my medications? The second case will be a 30-year-old Crohn's patient, 10 weeks pregnant, flaring with a new perianal abscess on no medications, only prior treatment 5-ASA. How do you now approach this 10-week pregnant patient who has a new perianal complication? And then the final case, a 29-year-old female with Crohn's who's in her second trimester, doing well, previously had been on adalimumab and infliximab, now is on ustekinumab every 8 weeks. What are the safety data with ustekinumab in pregnancy? And do you stop it in the third trimester or do something differently? And we can talk about breastfeeding as well. So, first case, I want to get pregnant, safety of medications. And maybe for the first one, we'll go down the line starting with Kim. Kim, 27-year-old, severe UC, deep remission for 2 years, anti-TNF. Let's say she's on infliximab, 5 milligram per kilogram every 8 weeks, and azathioprine, 150 milligrams a day. And she says, I want to stop my pregnant. I want to stop my pregnant. I want to stop
my pregnancy.
All right.
That's a whole different question.
Right.
We're not talking about that.
Freud has left the house. I want to get pregnant. Can I stop my meds?
So the simple answer is no. Do you want me to elaborate?
Yes.
Okay. So clearly, patients who go into their pregnancy who have flare or active disease are more likely to have flares throughout their pregnancy. And a flaring patient during pregnancy is going to have complications of low birth weight, preterm delivery, and so you really want that patient to stay in remission. You're describing a 27-year-old with severe UC, and I think even though they've been in a deep remission for 2 years, you have to be concerned that they're going to have problems during you've got to worry about problems during pregnancy, so I would not advise stopping the medication.
Maria, agree, disagree, other?
I guess I would take a slightly different approach to that, Miguel, and I think this is a time that I might pause and wonder if she needs to be on combination therapy at this stage, regardless of the pregnancy thing right now. And it's very likely that I might consider that this would be someone that I could safely discontinue the azathioprine. A lot has to do with how sick was it when she started it, which of the medications that I think really hit it out of the park. Is she in remission primarily because of the anti-TNF, or do I think the azathioprine is really having an important contribution? And after thinking about that, then if I think that it really was the infliximab that got her better, that she's been well enough, and I've documented deep remission, I might actually allow her to stop the azathioprine, because at the end of the day, that's the one that that is the most agonizing to describe to the patient because of that damn category D thing. There's also a little bit, although that's controversial, as you know, about anemia with azathioprine in the newborn. I mean, until I read that, I'm not aware that that's ever happened to a patient of mine, but I also don't know how carefully that's looked at.
All right, so let me pin you down before I move on. So Kim's going to continue both. She's sitting in front of you. Would you definitely stop the azathioprine? Let's assume the anti-TNF is what brought her into remission. Would you definitely stop the azathioprine at this point?
If anti-TNF got her into remission and her anti-TNF levels are good,
yes,
I would.
Okay. So you would stop azathioprine with all those caveats. Susie?
Yeah, I actually agree with both of my colleagues that, can she stop her meds? Yes, but should she stop her meds is the question, and that I would at this point, like Maria said, assess whether, it's been 2 years, I would congratulate her that she's done so well and that we're both happy that she's well. Maybe it's time to stop the azathioprine because she doesn't need it anymore. And that I also want to give a plug for preconception counseling clinics that are starting up. We heard yesterday from Gil that they have one at UCLA now. I would love to do it at Mayo, but we just don't have the right population to do it, but I think that there is a role for other larger cities that see a lot of these patients. Certainly the Rotterdam group is the model to follow, so that we know that there are better outcomes across the board if there has been structured preconception counseling, and these are the kinds of issues that get discussed there.
So you don't have young, fertile females at Mayo? Okay, we'll move on. Anita?
I also agree with my colleagues. I absolutely want to emphasize the importance of asking why, meaning why does your patient or is your patient asking in regards to, can I stop my meds? This is a great counseling, learning, educational opportunity to really discuss with your patients in regards to the safety of our therapies, the impact of disease with pregnancy, birth outcomes, etc. And so I think this becomes an opportunity for discussion with your patients, to educate them, to talk about the safety profile of your therapies. And to answer the question, I would say I too would consider potentially, at least after good drug levels, potentially de-escalating and taking the thiopurine off, but I would absolutely continue with the anti-TNF.
I'm sure Corey has some questions from the audience, but it sounds like Kim would continue both, the other three would stop the azathioprine with the caveats. I'll say all of you surprised me. I thought you would be 4 for 4, continue both, but I understand. So Corey, go to some of the questions.
Thanks, Miguel. There are a lot of questions here about drug levels, or specifically anti-TNF drug concentrations when you're going into pregnancy. And you had mentioned checking drug concentrations before stopping azathioprine. Are you keeping the same goals as far as where you want their biologic drug levels going into pregnancy, or are you altering things if you're stopping azathioprine and thinking about them getting pregnant? So maybe...
I'll give a plug to this really nice study out of Calgary that showed that infliximab levels go up during pregnancy. So that, they didn't see that with adalimumab. So it's actually, in my practice now, to consider checking a level in the second trimester because they are already in the potentially super therapeutic range, and if they're well, they won't need that third trimester infusion. And I'm holding it not because I'm worried about placental transfer, but if they're already super therapeutic, why do they need more? Because there will be more placental transfer to that baby.
Okay. One other question, if I can throw this in, is if you turn this case around a little bit and said this is a 27-year-old male who says, I'm on these medications and I want to get my wife pregnant, should I stop these medications? So
No.
Maria, anything that we should do there?
I think it's time to reassess whether the guy needs the azathioprine, but I wouldn't need to worry about the sort of the counseling about pregnancy. And that's,
So wait, just to pause on that for a minute. Are you worried with birth defects in males who are on azathioprine?
No. What about methotrexate? Susie?
Actually, Steve and one of his new mentors just published the World Review on methotrexate in men, and there was a real lack of any true data. So this is low-hanging fruit for folks to study. I think it's case by case for whether you're going to continue it. I actually have stopped it because of the oncology experience, but it's not based on a lot of solid data.
All right, so the take-home points from the first case are that anti-TNFs and thiopurines are safe during conception. The caveat that you heard from 3 are, do they need to be on the treatment any longer? Is the drug level of anti-TNF effective? And maybe they could come off. But I think the panel feels comfortable in pregnancy and breastfeeding, continue both if that's necessary.
And one more thing, and then I'll shut up and I'll let my other 3 for the rest of the time.
Not a problem.
that there are women who want to stop their anti-TNFs because they want to conceive, and there's actually data in the infertility literature of using anti-TNFs in infertile women who do not have IBD because of the amount of TNF that is circulating in their pelvis, and they use it to get rid of that TNF to help with fecundity. So if that's the reason to continue the anti-TNF.
So for your infertile female population at the Mayo Clinic, the subpoint is put up there for you. The anti-TNFs have been used to treat infertility.
Right.
Anti-TNFs and thiopurines do not need to be held in the last trimester of pregnancy. I know we skirted around that a little bit. Babies of mothers on anti-TNF should not get the live rotavirus vaccine at 2 months. So for the pediatricians in the audience, I think you probably know that already. But there still are levels of anti-TNF in the baby that are potential out to 2 months. So let's switch gears, and this is a different case, and this is another case, as I think Corey presented, the EBV positive patient with Crohn's and a young male on azathioprine that connotes the same emotional response. This is the pregnant woman who now comes in 10 weeks pregnant, flaring, with a new perianal abscess, no medicines, and her only prior treatment had been 5-ASA. How do you treat this patient with Crohn's disease and a perianal abscess? Let's go reverse order. So Anita, we'll start with you. What would you do at this point?
So to begin with, we need a little bit more of a workup, and recognizing that she's 10 weeks pregnant, we need to understand the impact of our workup potentially on being teratogenic or radiation exposure or treatment exposure to the fetus. And so in this situation, having a known abscess, we need to treat that with antibiotics, and we briefly talked about that earlier. We have to be careful with our fluoroquinolones, as that can really cause arthropathy and or cartilage damage to the fetus and the baby. And so we avoid the fluoroquinolones. And in this situation, metronidazole is fine and appropriate, as is amoxicillin or augmentin. And so with treatment of the abscess is part 1, and that's with antibiotics. If you want imaging and workup, we have to be careful with, again, radiation exposure. So we have to be careful with our x-rays, with our CAT scans. And in this situation, an MRI is appropriate. But we need to be careful with the exposure of gadolinium, as it does cross the placenta and can be teratogenic. So that becomes the initial treatment. And then we go, do you want me to keep going?
Sure.
Okay, I'm on a roll. And then we go to what sort of treatment we would actually utilize for a patient with Crohn's disease, with aggressive Crohn's disease, perianal disease. And in this situation, it's very appropriate for us to initiate an anti-TNF and recognize that for the health of both the mother and the fetus and baby, we need to control the disease pretty rapidly. So I would start an anti-TNF.
All right, so Susie, do you agree, similar approach, or do you do something differently? And actually, to follow up, what medicines would you not start in pregnancy?
Oh, okay. Well, I said that I would give my time to others because I was really a bully with that first case.
Maria?
So I'll let Maria and Kim talk.
Susie doesn't see pregnant women anyway, so.
I wasn't going to beat you. I guess you asked what we wouldn't do. I think that I wouldn't start azathioprine in someone who is pregnant for a couple of reasons. First is we don't have good tests to predict who's going to have an idiosyncratic reaction to azathioprine. So the last thing you need is someone to develop pancreatitis or a febrile reaction during their pregnancy, not to mention the length of time it takes for azathioprine to work. Quite different than if someone was stable on azathioprine, doing well, and you didn't want to rock the boat before pregnancy. We talked about the fluoroquinolones. It's a common misconception that metronidazole shouldn't be used in the first trimester, and that's been debunked. There's ample data that it's not teratogenic to use metronidazole because obviously there are many women who had trichomonas and were on it during their first trimester. I'm trying to think. The steroids are safe during pregnancy. A fistula patient, of course, we're not thinking about steroids, but if we're talking about luminal disease, we could consider that. And I think that maybe you said this, obviously the MRI wouldn't just be for the purposes of outlining what's happening with the abscess, which then will be drained by the colorectal surgeon, but perhaps to define what luminal disease one needs to treat, because it could, in the very best of circumstances, be that she has a limited perianal abscess and that in fact she has no active luminal disease. We could have gotten lucky that way. It probably isn't, but nevertheless that would be something worth investigating.
All right, so Kim, you're hearing MRI, what medicines not to start, colorectal surgery was brought up. What would you do?
So I think that I agree with everything that's been said, but I think that the first thing is to know disease activity, is to really be restaging the disease, because like as Maria just said, if it's a very superficial abscess, you may be able to just drain and treat with antibiotics and not have to add our more aggressive therapy at this point. Where's her disease been in the past? Has it been terminal ileal disease? Has it been mainly rectal disease? I think those things are all important. And we mentioned that, feel very comfortable starting anti-TNFs, would not start methotrexate, would not start azathioprine for the reasons that Maria outlined. So I think number one is I would restage, and I would clearly get our colorectal guys involved in terms of draining the abscess. That's the key thing right now, and then start antibiotics.
So quick question, Kim, and then I know Corey said he has a bunch of questions that have come through. So in terms of restaging, would you do a full colonoscopy or a flex sig, and what sedation can we give her?
Well, propofol is fairly safe during pregnancy. If at 10 weeks, we're starting to get close to the second trimester. Second trimester is going to be the safest to do many of these things. I think that if there may not be a reason to do a full colonoscopy at this point. You can do your MRI and get luminal imaging, and then you can see what the burden of rectal disease is with an unsedated flexible sigmoidoscopy. So I'd probably start off with an unsedated flex sig. If you're doing things later in pregnancy, you need to make sure that you have fetal monitoring and really make sure that you're keeping the oxygen saturation up in the patient.
All right, so Corey, I know you said you have a bunch of questions.
Yeah, there's some great, very practical questions here. One is about C-section versus normal vaginal delivery. Susie, we'll let you speak again.
So this is a case where you have a compromised anal canal, and I would be recommending a strong consideration for C-section. Now, sometimes in the real world, if this is her third or fourth child, that it may be that she, goes into labor and she pushes and out it comes before anybody has a chance to, to get the surgeon involved or the OB, in the operating room ready. So she may push that baby out and no problem, but that I would anticipate that she will need a C-section.
Out it comes. So
Out it comes.
what are you worried about in a vaginal delivery? Just to state the obvious, why would a C-section be preferred?
Well, and it was actually Ashwin who gave us the most recent data after only having a single paper from 1996 to show that you may not potentiate new perianal disease, but you're certainly not going to help existing perianal, and it may flare.
Right, and the other reality is if you tear or an
Right.
episiotomy into an active
It's not gonna
fistula,
heal.
that can be a complication. Corey?
Yeah, I'll pose this to Maria. There are a couple questions here about the safety of giving gadolinium or other IV contrast when you're treating pregnant women. Can you comment at least what's happening at Miami?
I thought gadolinium cannot be given
right,
during
in first.
pregnancy. So
For sure not in the first.
I think, but more importantly, let me add that although it might not give you all the detailed data that we need, I think we can get away with it. I mean, there's so many things we could do. We could do a fecal calprotectin. You could see if there's thickening of the intestinal wall with a non-contrast MRI. They can take oral contrast. So there's a lot of stuff that we can get, data that we can get from the MRI, that we can get from
Ultrasound,
fecal
too.
calprotectin.
There are radiologists who are interested
Apparently
in...
there are radiologists that can do an ultrasound of the small intestine. Okay, I haven't met them, but
We have a couple. We don't have pregnant patients at Mayo, but we do have radiologists who will
Okay.
do terminal ileal exams for us.
yeah.
This is good, actually. I thought you guys were going to be kinder and gentler, but it's nice to hear a little bit of debate here. Corey, maybe one last question?
Do we need to fight?
For Anita, one last question. There are a lot of questions here about choice of anti-TNF therapy, and we've heard about the potential benefits, at least hypothetical benefits, of certolizumab pegol in pregnancy. And there are a number of questions here. Is that the obvious choice in this patient, or would you open it up to any of the anti-TNFs?
I'll start with saying that we should open it up to all anti-TNFs and recognize that the safety profile of all of our anti-TNFs is well known, that it's safe during pregnancy. With that said, certolizumab, and the reason that there's an appeal to it is because we have data and we know just molecularly how it's designed. It does not cross the placenta, and so the safety profile, because the levels are not detectable in cord blood, seems to be perhaps suggested to be safer. But I would open it up to all anti-TNFs, and especially with fistulizing perianal disease, this is where we want to get appropriate treatment pretty rapidly in this patient who's now pregnant as well.
Great. So key take-home points. Fortunately, we write these before the panel discusses, so we always get a little worried you're going to disagree with what we wrote. But never use methotrexate in pregnancy. Stop at least 3 months prior to conception. Do not initiate thiopurines due to the risk of pancreatitis and idiosyncratic reactions. Avoid fluoroquinolones. Augmentin and metronidazole are okay. All biologics are safe to start in pregnancy. Certolizumab does not cross the placenta. Endoscopy with propofol, if you have to use sedation, is acceptable. MRI without gadolinium is safe. If surgery is required, the ideal timing is second trimester, especially for the sick colitic patient who may need a colectomy. C-section for active perianal and perineal disease should be the choice, and then avoid vaginal delivery in these cases. So let's move to the last one in terms of pregnancy. So safety of newer biologics in pregnancy. We already alluded to this, but let's dive down a little bit deeper on the ustekinumab question. So this is a 29-year-old crone, second trimester, doing well, previously on adalimumab and infliximab, now on ustekinumab every 8-week injection. So we'll go again. Kim on the start for this. What are the safety data for ustekinumab in pregnancy, and do you hold or stop it in the 3rd trimester?
Well, I'll answer the second part. I would not stop it in the 3rd trimester. What I would try to do is I would try to do the timing so that I was giving it early in the 3rd trimester, and then they get their dose right after delivery, because there is some data that when you give the biologics, that there's a linear relationship with drug level in the baby. So I wouldn't hold it, but I would try to do the timing of that. The safety data is much less with ustekinumab than many other things. There's a couple of case series in psoriasis, and there don't look like that there's any safety concerns with ustekinumab. And I think last year at DDW, UMA presented an abstract, and there was negligible in the, I think it was a breast milk study. Out of 3 patients, 1 patient had negligible levels in the breast milk. So it's an IgG1, so it will have active transport across the placenta, but we really haven't seen any major safety concerns right now.
So it sounds like you do the same thing you would with one of the anti-TNFs. What about rotavirus at 2 months?
So I think that the recommendation is we really don't know, but you would still avoid the live vaccine at 2 months.
All right. Maria?
Yeah, no, I agree with absolutely everything that Kim said.
So nothing different?
No, I think that we can apply all the same principles, but I probably would not vaccinate, because again, we expect that IgG1, that it's going to cross into the baby, and interleukin 12 and 23 are probably important for all sorts of immunity in the baby.
All right. Susie?
No, I totally agree.
Wow, 3 for 3. Anita?
I just want to get along with them. I agree.
I'm saying, this is such a kind group. Just wait for the surgeons. We should actually mix the surgeons with you guys. Corey, I don't know if there are any questions that are popping through, but maybe we can go through some of them now.
Yeah, there's some uncertainty, I think. There are a couple people who mentioned, hold on, I thought we were taught to stop biologics in the 3rd trimester. Now it sounds like you're saying to keep them going.
No, what we said was that what you want to do is time your last dose to be in that very early 3rd trimester, because you're going to cross after week 20. So that's where, but the trajectory for that placental transfer is at week 32, where it just takes off.
All right,
And
so let's pin you down. She's due
Okay.
February 1st.
She's due to deliver or
To
due for her
deliver
drug?
February 1st.
Okay. Like,
That requires math.
Beginning of
You need a
December.
calendar.
How soon before delivery do you give the last
okay,
dose
well,
of ustekinumab?
I want her to stay well, because if she has been doing well and I can give her that dose at week 30 to 32, it's going to cross, but it's not going to be a huge amount, and that should keep her well until she delivers.
Okay.
And so this whole thing about stopping in the third trimester, well, is it that you are stopping at week 36, or are you stopping at week 32, and understanding where the kinetics are and how that patient's doing?
So Maria, do you do the same thing, and do you stack the doses if they're off cycle? So for example, if you're saying 32 weeks is when you want to give that last dose, but they had a dose, say, at 27, 28 weeks, would you give a dose basically 4 or 5 weeks apart to get that last dose in at 32 weeks?
Well, I think, it depends on how endlessly you want to obsess over it. It would be very considerate of the child to be born at trough. That would be the most considerate, and to have the C-section done at trough, which is why C-sections are so civilized, because you can pack your toothbrush and you can plan all the biologics around that C-section date. I think if it means having to give them usually what we do is for those last 2 doses, if you back calculate, then I try to give them the penultimate dose, maybe a little 6 weeks. The next dose is 6 weeks. It also really depends on how much was on the line. If they've been fabulous for a long time on whatever they've been on, you probably can hold that last dose and not be agonizing over it. And UMA's data, I think it's UMA's data, at least for the anti-TNFs, has shown that actually women get away with having their doses held in that last trimester. Even when we did that, I'm not saying you should do that, and they did okay. So I think that for people who are really doing well, probably they can have a little mini dose interruption.
Yeah.
All right, so Corey?
So there are a couple of comments here that's nice and all for every 6 or 8 week dosing drugs, but what do you do about those on weekly Humira, which is a little more complicated? Anita?
So that also becomes, obviously this patient that is now on weekly Humira probably has more severe active disease that you're trying to control. It goes back to what Maria was saying earlier. How sick initially were they? How active was their disease even pre-conception, to recognize what you're going to do with now a weekly Humira. With that said, if they're doing well throughout their pregnancy, disease is controlled, disease activity is controlled, then you could potentially consider in that situation to stop it at least 4 weeks prior to delivery. Again, it goes,
January 1st.
So yeah, that math I could do, January 1st. But otherwise, listen,
That's 4 doses you're holding.
But if we go with, and then the other part is, if we go with the Toronto consensus guidelines, you could actually technically even continue it throughout, right? Up to the very end. So it goes back to how sick were they before, how active was their disease before, to know what to do.
Because some moms will say, I'm not stopped, I was sick, and I am doing well, and I don't want to rock the boat. And I understand my baby will have this, but I won't give them rotavirus. And we have data out to 4 years now,
Saying it's safe.
saying that it's safe, and that actually there's rat data, not that we take care of rats yet, but that actually anti-TNF exposure is, actually Maria does take care of rats.
Yeah.
That anti-TNF exposure in utero actually helps with neurologic development. So these kids may be smarter, or that they may have less of a risk for autism or other developmental issues.
Wow,
I see
take-home
the ad.
points. You're not going to see those on the take-home
I
points.
see the ad coming now.
Yeah, this is, for all the reporters in the room, Susie Kane, Mayo Clinic. All right, so Corey, last question, and then we'll wrap it up.
All right, to Kim, there's some questions here about patients, women going for C-section. We talk to our colorectal surgeons all the time about appropriate timing to restart medications after surgery. So C-section's a surgery. So what time are you comfortable with, and how do you collaborate with the obstetrician about restarting, let's say, biologic therapy post C-section?
So I would wait to make sure that they haven't had a complication from the C-section, but I, in general, would feel fairly comfortable if it was uncomplicated about a week after. And for vaginal, maybe a couple of days after.
Great. So I think the take-home points we've already hit, but ustekinumab data in pregnancy and breastfeeding so far are limited but safe. Give the last dose 8 weeks prior to delivery, and until there are more data, do not vaccinate the newborn with live virus to rotavirus. after delivery. So I really want to thank the panel. That was an excellent discussion, and we'll switch gears now.